Morning, everyone. This is Rochelle Seeger with the Foundation for a Healthy Kentucky. I work here at the Foundation as a Community Health Research Officer, and I'm so glad you all have joined us here today on our Health for Change webinar, Practicing Health Equity in Kentucky. Thanks for joining us today. Glad you're here. First, a few reminders. This webinar is being recorded, and we will be posting the recording and the slides from today's presentation on the Foundation's website in the next day or so you'll have those slides available to you. Also, if you're logged into the web portion, you can ask questions via the audience question section in that chat. And those questions come directly to us, all the presenters here today, to myself and Dr. Bush and Krieger. They can see those. They aren't broadcast to everyone. So if you have questions or comments, please send those in because we will have time at the end of the hour here today to get those questions to Dr. Bush and Dr. Krieger. The Foundation for Healthy Kentucky's mission is to address the unmet health needs of Kentuckians. And this was a photo from last summer when we were in Whitesburg, Kentucky at Pine Mountain. We had a nice event there with Kane Community Kitchen. Also part of the Foundation's mission, we do this work by addressing the unmet health needs of Kentuckians by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. And you can see this final piece of the Foundation's mission is exactly what we'll be talking about here today. You might already know, but the Foundation's website, healthy-ky.org, you can find a lot about the Foundation's current work, also recordings of past events, many of the reports, and also you can find there a link to sign up for the Foundation's e-newsletter if you aren't already receiving that, and that's on our website, healthy-ky.org. Next up, a few reminders. If you aren't already part of the Foundation for Healthy Kentucky-led Coalition for a Smoke-Free Tomorrow, they're doing lots of fantastic work currently, so you can also join their newsletter. Check out what they're doing at smokefreetomorrow.org. And here today, this series, Health for a Change, the Foundation began in 2011. It's also located on the Foundation's website. You can click the Events tab and go look at Health for a Change. There you'll see listed all of the prior events, many of the slide decks and recordings from those webinars, and also see the upcoming of current offerings. Health for a Change has reached nearly 2,000 people across all 120 of Kentucky counties, so I'm really excited for that. And also, I welcome ideas from folks just like you who are working in health improvement space, are part of a health coalition in your local community. I welcome ideas for topics or speakers that you want to see in this training series. So Health for a Change, as I mentioned, was started in 2001, and it is working to support the health coalitions, the health departments, and folks just like you who are working to improve health in Kentucky. These are all pictures from our events last year. We had a health infographics workshops. We worked with Kentucky Center for Smoke-Free Policy. The Louisville Free Public Library offered some information on finding grants and grant writing. Kentucky Injury Prevention Research Center talked about all of the great wealth of drug data and injury data that they have on their website. The gentleman there in the photo with his arms raised in his victory stance was the chef at Kane Kitchen in Whitesburg, Kentucky, who prepared a great meal, and we had a coalition building workshop there in Whitesburg. And the other photo is on the lawn of the Michelle and Nathan Howells Farm in Halfway, Kentucky, where we talked about food access, and food policy in the Bowling Green area. Those are just some of the offerings we had last year. I would love it if you would mark your calendar. March 4th, our next webinar, we'll be talking about the 2020 census, very important to all of our work and the future of work here in Kentucky. Census is going to be here before we know it, so please join us where we'll have state and federal U.S. Census Bureau, leaders who will tell us all of the updated information about the 2020 census. Next up, why we're here, definitions and framework on health equity in Kentucky. On this slide, I just point you to the healthy-ky.org, our foundation website. And if you click on the About Us website, you can see the foundation's mission, vision, and also our values, because our values are definitely fueling our work in health equity. Values like collaboration and leadership and effectiveness and respect and integrity and policy equity. All of these things tie into our work in health equity. I brought to you this morning a few definitions. This is from the World Health Organization that identifies health inequities as systematic differences in opportunities groups have to achieve optimal health, leading to unfair and avoidable differences in health outcomes. We can look at another definition of health equity. This is from the federal government, Health and Human Services here in the United States, around the Healthy People 2020 definition of health equity. It has some similar guidance, but focuses on attainment for the highest level of health for all people, valuing people equally, addressing avoidable inequities, historical and contemporary injustices, and the elimination of health and healthcare disparities. You can check out the Healthy People 2020 website that shows the whole schematic, the definition, and the framework that Healthy People 2020 does its work by. This next photo is one that you may have seen lots of places in discussions of health equity, inequities, and how people just like us can address that. So this symbolically shows there on the left an equality situation. All of those kids outside the baseball field would have the same size boxes. If we think about equity, it's giving the shortest kid higher boxes so that he or she can see over the fence. And we can see this in this schematic, there's a reality section where one person gets many of the boxes or resources. But what I really wanted to do is point you to this link to Wired magazine, which talks about the origin of this schematic. Craig Frohl from University of Cincinnati was the first person that developed that. You can see how that definition of health equality changed and evolved. And how can we ask questions and understand health equity by thinking about this example. I always ask, why are the kids outside the ball field? Why can't we get them tickets to enjoy the game? So again, just another framework on thinking about health equity and how we can understand it in our communities and for the work that we do. Another model is a socio-ecological model. So you can see there's different circles that represent individual, interpersonal, organizational, community, and public policy. A good example currently is the Foundation for Healthy Kentucky's work and other groups across the state on policy work at the state level, for example, the e-cigarette tax and other policies currently at the state legislature. So for example, if we think about public health policy, we could see how a state law in Kentucky making all indoor places smoke-free would have the most impact on the most people in Kentucky. If I, which I've done in the past, give a smoking cessation class, that's in the smaller circle that would just reach one or two individuals, helping them hopefully to become non-smokers. But you could see the public policy, that largest circle, we could have the most impact by having a state or local law. Part of the foundation's work around health equity, I'll give you a few examples. One, the series here today. The foundation looked in 2011 at some of the grants and organizations that the foundation was doing work with and really saw differences in readiness, differences in skills around grant applications and doing this work. So the foundation has put money aside every year to do this Health for Change training series so that all of us, coalitions, individuals, can move forward and do better work. again, the foundation's work happens on a bunch of different levels. So, for example, the foundation's initiative promoting responsive health policy and investing in Kentucky's future in prior strategic plans, we worked with them to think about the evaluation reports and how that evaluation could be more equitable so that those organizations could also not just report to the foundation, but get really the work and measures and data that they needed to do the work in their local community. And finally, why we're here today, we have the endowed chairs. So on the foundation's beginnings, the foundation funded 2 endowed chairs, one at University of Kentucky and one at University of Louisville, to look at research in health policy in urban and rural communities in Kentucky. So I'm very excited to have with us today the endowed chairs. At University of Louisville, Dr. Karen Krieger, and endowed chair at University of Kentucky, Dr. Matthew Bush. And now I'm going to turn the call over to Dr. Karen Krieger. Dr. Krieger, welcome. Thank you for joining us today.
Thank you, Rochelle, for the opportunity to speak to those of interest in health equity. We've had several definitions of health equity, and this is sort of redundant, but it is valuing everyone, with focused on ongoing societal efforts to address these avoidable inequities and inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparity. It is important that we understand health equity because it's a key determinant of economic and social development with a positive impact on people's life changes and opportunities. This is a mapping of Jefferson County, Kentucky, and the lighter areas are the ones that have the least life expectancy in Louisville Metro. The darker green areas are the ones with the longest life expectancy. So in certain areas of our county, people are living 12 years longer than others. And this is a reflection of the framework of health equity. So this slide has been divided into the social, economical, ecological parts affecting health, and a medical model. So the upstream part, discriminatory beliefs of race, class, gender, immigration status, national origin, sexual origin, and orientation disability as a social factor. Institutional power is represented by corporations, government agencies, and schools. And then social inequities and neighborhood conditions that are both physical and social, residential, segregation, workplace conditions. This leads over to the medical model. So we have individual health knowledge, downstream, risk behaviors and factors that people have for smoking, nutrition, physical activity, and violence and chronic stress. Healthcare access leading to disease and injury, whether intentional or unintentional injury, chronic disease, infectious disease. And all of this ends up downstream to mortality, infant mortality, life expectancy of adults. It's reflected on the prior slide for Jefferson County. So my work has dealt with this model that I discovered several years ago from Margaret Whitehead. And I've tried to implement projects that make changes based on the portions of the model. So one of the projects is a collaboration between the Office of Diversity and Inclusion on the Health Sciences Center and the Louisville Free Public Library, offering an African American history film series. It's in its 3rd year. It deals with the discriminatory beliefs in our society that contribute to health equity: race, class, gender, immigration, national origin, sexual orientation, disability. The first year, we did generic films because there was no film access, no movie theaters in a large segment of the city. The second year is represented by this slide, in which we focused on medicine with the immortal life of Henrietta Law. Then we went to LGBTQ issues with the movie Moonlight, and then pop culture with Black Panther, and then social issues with the movie 13. after the movies are shown, there's a panel discussion. Panelists are made from the university and from the community. So, for instance, on the first movie, The Immortal Life of Henrietta Locke, we had representatives from the Institutional Review Board from the University of Louisville. We had a psychiatrist there as well to introduce and talk about with the community some of the issues that were seen in that film. For Moonlight, we had people from the Office of the LGBTQ Centers and community radio host who had podcasts on LGBT issues. We also had a homeless shelter specialists that worked at St. John's that were there. For social justice and the movie 13th, we went to history at the university, but we also brought in the Associate Director of Operations of the Bail Project for that panel. This year's film series were all free true stories of African American history. In March, NPR is going to do a 4-part series on slavery in Jefferson County, and we were asked to incorporate films that were historically true. The films that were chosen were The Free State of Jones and Best of Enemies and Black Klansmen and When They See Us. And again, they were followed by panel discussions. The Free State of Jones is a story about Jones County, Mississippi during the Civil War, which was unionized by Confederate disenchanted soldiers and African Americans. On that panel, we had a professor from the Brandeis School of Law and a historian from Pan-African Studies. Best of Enemies was about the school integration in Durham, North Carolina in 1969. On that panel, we had a representative from the Southern Poverty Law Center, the director of the Civil Rights Memorial Center in Montgomery, an ACLU member from Louisville, as well as the dean of, we had a historian on that panel as well. Black Klansman was interesting. The story of, true story, in 1979 of Colorado Springs. We had an FBI, the assistant special agent of FBI in Kentucky, was on that panel talking about hate crimes and how they investigate. We had law enforcement with the chief of public safety for U of L and the Louisville Metro Police Department commander for media and public relations, as well as a professor from Israel visiting on relationships of blacks and Jews. And When They See Us was the one we just finished this past Sunday. And that also was interesting with a police officer from the 2nd Division, which is the most highly impacted health disparity area in the city. That was a true story from the Central Park 5 in 1989. We had the chair of the Department of Social Justice and Change, as well as a media specialist on the portrayal of African American youth in the media. So in the years, we've looked at how diverse the population comes to our viewing. We have 50 to 60 people that show up for the viewings, and they represent just about every zip code in Jefferson County. Another project that's here is the Health Equity Learning Project. It's a collaborative model providing screening services of chronic diseases at a site in the West End, dealing with discriminatory beliefs, institutional power, and disease and injury. These are students from all the schools. This is a set site that's been operating since 2016, doing basic screenings for hypertension, diabetes, asthma, obesity, BMIs, and cancer. But it also includes food pantry services, cooking classes, exercise classes, workshops, luncheons, and speakers. So this morning I left after signing up people for a colon cancer prevention awareness luncheon, and basically we had 7 criteria for risk for colon cancer, and that was announced to a group of 160 people. And people having those risk factors, we chose the people that had 3 or more of the 7 to invite them to a lunch. But that is a cooperative with different organizations. An insurance organization, CareSource, merged with Dare to Care to provide health-related funding for us to put on such events, and then it's held in a site in the west end of Louisville. These are some of the collaborators for the Health Project, Health Equity Learning Project. So we have the Science Center and all the schools from the Health Sciences Center, Louisville Metro Department of Health and Wellness, and Redeemer Lutheran Church is the site, Dare to Care, CareSource, and Aetna Insurance help provide the funding, the staff. James Grant Brown should be on there as well, the James Grant Brown Cancer. Compassion Clinic is a mobile clinic that provides those same services, dealing with discriminatory beliefs, institutional power, and disease and injury. And so it goes to disparate areas within Metro Louisville identified by the 2017 Health Equity Report put out by Louisville Metro Department of Health and Wellness. The volunteer staff is composed of students, staff, and faculty, and we collaborate with community organizations to provide this working environment, which these are in underserved areas in which many of the students have never, ever been. So it has a dual purpose of providing outreach, screening, linkage to medical homes and care, but it also takes our students to places that they see the patients from, but they may have never gone into their neighborhood. Another project is the Youth Violence Prevention Symposium. It's a year-long event that started in 2018. The location was chosen based on the number of homicides in the city of Louisville, which have been growing in the last 5 years. Zip codes 402, 10, 11, and 12 are targeted. And again, this represents institutional power, social inequities of neighborhood conditions, social, physical, residential, and workplace, as well as risk factors and behaviors such as smoking, nutrition, physical activity, and of course, violence and chronic stress. A neighborhood association, the Shawnee Neighborhood Association, approached us about having a symposium that would speak to the effects of violence on youth in the community, but also giving parenting skills. This is a list of the planning committee, which is all community-based, and all the funds for the free symposium that lasts 8 hours, providing breakfast and lunch, that participate in this yearly symposium. And as I said, the grant money comes from all of these different resources. These are some of the service providers that appear at the Youth Violence Prevention Symposium. And these are all, every mental health providership in the county was represented at each of these symposiums. Plus, we recruited service providers that provide services for the youth in the area, in the city. The symposium is composed of large group sections and then smaller group sections. We update the city on what the statistics are in Louisville, review recognition of types of youth violence, its effects, and treatment. And this year, actually, they have chosen as their themes ACEs, Adverse Childhood Experiences, and Conflict Resolution. So there'll be 2 group sessions based on that, and then the small group sessions will deal with opportunities. Here, this is from 2019. We had psychological first aid as a small group session, how to be successful in schools, social media and human trafficking recruitment, the city resources for violence, gun safety, including giving out gun locks, and how to stop bleeding of gunshot victims. We had a specific youth track that dealt with conflict resolution, sexual violence and its ramifications, and the introduction of psychological first aid tools for youth. Youth were middle school and high school students. As I said before, all of the funding was collected from the Louisville community and its collaborators. There were youth incentives in forms of door prizes. We had 17 vendors in the atrium of the conference center in which people could interact during their time at the symposium. No one paid, whether they're vendors or the people coming to the session. And these are some of the pictures of the individuals from 2018, our very first, that participated. Some were speakers, some are the people that were there to come Uh, one of the sessions happened to be on victims of abuse, and we had about 5 or 6 wheelchair-bound young people at that point. HIV is another area. If we look at what the mortality in our county happens to be, it's cardiovascular, it's cancer, it's COPD, infectious disease. Half of all the HIV positives in the state of Kentucky are in Jefferson County, and half of those are in the west end of Jefferson County. So we partner to provide services to support the population. There's a camp Heart to Heart, which is in its 20th year. It provides a summer camp for children with HIV the children are coming from families that are affected by HIV. Their caregivers are positive. Then there is a monthly dinner at this West End site that provides dinner for the patients, their families, and support people. All of these services are free. And we also provide lectures on HIV and PrEP and exposure through grants and patient care for both HIV, PrEP, which is pre-exposure prophylaxis to HIV, and PEP, post-exposure prophylaxis. We work with SANE, the Sexual Abuse and Social Examiners Program, that is housed. We were one of the first needle exchange sites here, and at that church, what we had to do was first to convince the church to support the needle exchange at that time, fans, and we surveyed 100 homes in the community surrounding the church to see if the neighborhood would be receptive. 96% of the homes that we surveyed were in favor. The church agreed because the men keeping the yard of the church, which is on the corner, 37th River Park, was finding needles in the lawn. So they were incentivized to participate in this program. Church liability wouldn't support the church supporting this. This church has done HIV testing for the last 20 years. So we have to find ways around providing these services. Volunteers of America wrote the church in as an umbrella for liability for the needle exchange. And the Metro Health Department provided the HIV testing and hepatitis C testing under their liability services. Through this venue, we were actually able to offer hepatitis A vaccinations, not just to those accessing the needle exchange, but because of their activities at the site, they were able to do this. Anytime we reach patients through monitoring or surveillance of chronic illness, we link to the medical homes, making available to them the contact information, in some cases calling to make the appointments. People that are discharged and their medications are not on formulary, for their insurance company, we're able to provide 30 days on a formulary equivalency for their medications in an attempt to move the needle for health disparities and medical health inequities in this area. So these are our collaborators for our needle exchange: the Redeemer Lutheran Church, the Louisville Metro Department of Health and Wellness, the Harm Reduction Coalition, which gives out our Narcan kits, and Volunteers of America. The immunizations, as I said, we've been able to give hepatitis A vaccination to the community, not just those involved in the needle exchange, but the Dare to Care sites. Influenza vaccinations were provided through funding and staff to administer them, as well as having a site. So we found that the Dare to Care food source was a very effective site in recruiting our patrons to serve. So I'm back to the framework of health equity that I started with. The social ecological part upstream, leading to a medical model downstream, which eventually leads to life expectancy and infant mortality. Practicing health equity in Kentucky requires knowledge of the 4 C's in the communities: coordination, communication, cooperation, and collaboration. And in your individual communities, you need to know the needs that affect them and secure buy-in by the affected community and populations. and began forging connections between institutions, corporations, and community-based facilities, churches, organizations, coming to mutual needs and concerns. And I thank you very much for your attention, and I did make my quota of time, and I believe we'll have time at the end. Thank you, Rochelle, and thank you, Kentucky.
Thanks so much, Dr. Krieger. Now we'll have a presentation from Dr. Matthew Bush from University of Kentucky. Welcome, Dr. Bush.
Thank you, Rochelle. It's an honor to be on this call and to be able to talk about a topic that's near and dear to our hearts. I think it has value for listeners of lots of different backgrounds. And thank you, Dr. Krieger. I think that's a fantastic presentation, a tough act to follow, but I'm going to do my best. So I'm going to talk to you about a topic that's different in its focus and a little bit broader in focus as well. A topic entitled Extending the Reach of Surgical Care by Bridging the Gaps. And this is an area that I come to from as a surgeon within healthcare. I'm an ear, nose, and throat surgeon. And there is a lack of research related to access to care as it relates to surgical services and the need for surgical services, sometimes delays in access and delays in seeking surgical care, certainly that may potentially influence outcomes. And so I want to talk about some topics related to surgery and access to care. These are my disclosures. I have NIH funding for research that I do here at the University of Kentucky, and none of these disclosures relate to any of the content that I'll be discussing, and there's no conflicts of interest. I grew up in West Virginia, and every West Virginian is aware of Bridge Day. Bridge Day is a sort of a state holiday in West Virginia. Bridge Day is typically in October of each year, and it involves some very interesting and brave individuals who are willing to hurl themselves off of the New River Gorge Bridge, as demonstrated here in this picture. The New River Gorge Bridge is one of the largest bridges in the United States. This unbelievably large steel structure, which is a feat of engineering, is quite a high distance away from the New River, which is below. This New River Gorge is an unbelievably expansive divide in which the New River travels through. In spite of its name, the New River is not actually new. It's one of the oldest rivers in the world based on some geologic studies, and it actually got its name of New River in just some cartography and mapping of territories throughout the westernmost parts of Virginia during some frontier days. But this picture, I think, is valuable in trying to consider the gaps that we might face, as it might relate to healthcare, or as it might relate to education, as it might relate to lots of different resources. And I think it's useful in a practical sense to think about a gap that we might need to bridge. And so as I would consider disparities, I've asked myself and I've asked colleagues in our field, at least within the ear, nose, and throat surgery fields, of what disparities are relevant to surgical specialists. Often healthcare providers have patients show up in their office and are quite busy seeing patients, and sometimes in the busyness of healthcare, it may not be something that's an issue that one might be aware that there's many patients that may never grace our doors or may never come into our healthcare centers that may actually need care. So I think it's a topic that's worthy of discussing no matter which the discipline. When I consider surgical care and surgical services, there is a gap between novel research, developments within research, innovations in the technology, the types of care that can be provided, and then translating those into clinical practice. There is a great gap, often due to time, due to the cost, due to resources, and sometimes because of a lack of expertise within navigating implementation of evidence-based research findings into clinical practice. And this is certainly something that I'll expound on in just a moment. Another gap that we face within modern healthcare and first world healthcare is subspecialty and surgical training and expertise. Surgery has been very slow to change in its diversity and inclusion, and thanks to lots of different efforts that are occurring within the American Medical Association as well as the American College of Surgeons, we're seeing changes that are occurring, but there are many individuals who would be fantastic clinicians and surgeons who are not getting access to surgical training and expertise, and that is a gap that needs to be addressed as well within surgery. Additionally, we just think also about evidence-based care and how do we provide care that is a part of what we would consider the standard of care based on research evidence and integration of that evidence, and how do we actually reach the populations who need that care. We may also consider in light of the frameworks and in light of the content that you've already heard in this presentation from my colleagues, there is a need of considering equity as it relates to access to care. That is full access to and full utilization of evidence-based care. And there is a gap between that care and the populations that need it. So when I also consider health surgical disciplines, I'm poised with a question of what are health and healthcare disparities that are relevant to surgical disparities. It may be different than what an endocrinologist or a pediatrician or a family practitioner may face. Well, another definition that you may see in health disparity, further expanding upon my colleagues' definitions, disparities could be defined as differences in health and healthcare between population groups. And these disparities can occur across many different dimensions that could include race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. When I consider the field of otolaryngology, it may be a smaller field considering the overall number of physicians that are in the United States, but there is an area within the ear, nose, and throat realm where we have identified some clear disparities that need to be addressed. Within the ENT, or ear, nose, and throat realm, I'm an ear specialist, so I focus a lot on hearing health care and conditions that affect the ear, as that may involve problems related to hearing or balance. And the World Health Organization has identified hearing loss as a global healthcare issue. There's over 466 million people globally who suffer from some degree of hearing loss, and the burden of that disease and how it influences employability, daily life and functioning and communication continues to be very high in spite of advances in diagnosis and in spite of advances in treatment options. There still is a huge global burden of disease that hasn't really had much of a dent made in it. Based on some research that we've done here in the state of Kentucky, we have found that there are significant delays for both adults as well as children in the diagnosis and even the treatment of hearing loss that are based on socioeconomic factors, that are based on education factors, that are based on geographic location issues as well. there is an underutilization of treatments that actually may provide some benefit for hearing loss as well that has been identified. Some work that's come out of Freeman's team in 2018 indicates that there's actually limited access to multidisciplinary surgical teams. Certain types of complex cancer care or other types of diseases require a team of specialists to be involved, and individuals based on ethnicity or race or location or sociodemographics may actually cause and be connected to limitations in access to that type of surgical care. Well, what causes these healthcare gaps or healthcare disparities and inequities? Well, this is another definition which comes from the Henry J. Kaiser Foundation, that these causes can be complex and an interrelated set of individual, provider, health system, societal, and environmental factors that can contribute to disparities in health and healthcare. And classically, we may consider those as the social determinants of health. And you've seen a framework identified like this already that sets up different categories of areas that may influence health and healthcare, including economic stability, physical location and environment, education, access to food and nutrition, community and social context, as well as the healthcare system. There's been some work done by Terrain et al. That's been published in a Journal of American College of Surgeons that takes a different look and perspective of those social determinants of health and actually applies that to more surgical disparities and in more of surgical fields and interaction of patients with surgeons. Many patients may not have as much of a degree of anxiety or concern with seeing their family physician or their local pediatrician, but when they have to visit with a surgeon, that often raises the stakes and raises the anxiety and even the blood pressure perhaps a little bit, with perhaps a fear that perhaps surgery is looming in the future, and what might that entail. But these disparities can be connected to patient factors, provider factors, system and access issues, clinical care and quality, and then post-operative care and rehabilitation that could also influence how patients do following surgical procedures. So if we were to, again, use this framework from my West Virginia roots, thinking about these surgical factors that influence or relate to the gaps, we could consider the patient factors, provider factors, system and access issues, and the clinical care and quality and the post-operative care and rehabilitation as factors that widen the gap and further may cause a great divide between the full access and utilization of care and then those populations that may need that care. When I consider, again, my field and where I've been involved, I think it's been a quite eye-opening exercise to consider the gaps that are influencing that. Hearing loss itself is linked to low educational attainment, low income, and unemployment. It's been published by a research colleague of mine at Duke. And there is continued disparities in the type of providers that are available in some subspecialties within urban and rural locations. Based on some work that we've done, we've identified that parental educational level is actually associated with how the child outcomes pan out with children that are born with severe hearing loss and may need a cochlear implant, that the parental education and parental self-efficacy and other aspects of parental behavior greatly influences the long-term outcomes. Some work that's been done in the neurosurgical fields, done by McKee et al., has identified that there are racial and ethnic minorities that are likely to be treated at lower volume centers that may not have that same type of multidisciplinary expertise And that could actually affect the outcomes of individuals within those different groups. So why do these health and healthcare disparities matter? Well, this is not a difficult case to make, but just to state the obvious and articulate that these disparities certainly affect the groups that face the disparities. That's an obvious thing. But it does overall limit improvements in the quality of care and health for the broader population as well. The disparities affect all of us, even for those that stand on the highest number, the most number of boxes, tying back into Rochelle's diagram that she had shown earlier in the presentation. And additionally, these disparities result in unnecessary costs. $93 billion in excess medical care that can be attributed to disparities. $42 billion lost in productivity per year based on ineffectiveness and inefficiencies in healthcare delivery because of disparities. And then also just economic losses and just the loss of the sanctity of life of premature deaths in children because of disparities. Well, what can be done about disparities in surgical subspecialties? Well, that's an easy answer. It's complicated. It's a complicated problem, and it's probably a complicated solution that's not a quick fix. Based on some of that research that I had mentioned from the Terrain et al. Regarding the adaptation of the framework of the social determinants of health in the surgical disciplines, this has influenced actually a national agenda for surgical disparities. This is some work that was recently published in 2010 by Hayter et al. And this outlines basically a focus of research and of a quality improvement and resourcing and even policy related to trying to move the surgical field forward to address disparities that occur within this discipline. And this doesn't just apply to ear, nose, and throat surgery. This is a broad approach to address surgical care of all different types. An important first step and first part of this agenda is to improve patient-clinician communication, to develop a culturally dexterous surgical workforce. Surgeons that are able to meet patients where they are, and that's not only geographically, but that is emotionally, that is psychologically, that's spiritually. Being able to communicate and understand and have dialogue back and forth is a critical part of care. And there is much that needs to be done in not only the education, but also in ongoing professional development and with actual care delivery and programs and research that's done to improve this patient-clinician communication. And as I alluded to before, that patients are sometimes just terrified of having to go see a surgeon for the fear that the knives are in the other room and that there's instruments and things that could be harmful and could be pain-inducing, and it's often something that patients may avoid. So this is a critical area of focus for this national agenda. Secondly, there's a need for community engagement and outreach through technology, utilizing technology to then reach out geographically to extend our borders for what surgeons are able to, where they're able to provide care and interact with patients. This can come through educational resources, through improved health literacy regarding surgeons, surgical disciplines, and care that surgeons can provide, and additionally in working together through shared decision making. This could involve potentially telemedicine connections with surgical teams before or after surgery. There's lots of different opportunities to utilize technology to improve community engagement and outreach. Thirdly, there is a need to improve care at centers that have a higher percentage of minority patients. patients that have lacked the multidisciplinary team, that have lacked some of the support, but yet the centers that are seeing those that are in some of the greatest need or have some of the lowest resources. So how do we identify those centers? How do we improve the care? How do we improve the recruitment of surgical teams to provide care for those populations is a critical part of health planning and health policy in the future. Next is the need to evaluate long-term effect of interventions on functional outcomes and patient-defined quality of life. And this is a critical issue as well because we want to improve patient care. We want to improve the effect of our interventions on things that matter to patients, not whether the tumor was removed or not, but does it improve the patient's quality of life, their ability to interact with their family, their ability to return to work, their ability to live pain-free. Those are important things to change and to incorporate metrics of success in surgical interventions that have more to do with just survival or tumor removal or a completed successful surgical procedure. Lastly, one of the major agenda factors is to improve patient-centeredness by evaluating patient expectations, to bring patients into the surgical decision-making as well as understanding expectations and how we inform the type of outcomes that we want to measure and how we would assess quality of life. That's critical to really perform research and be engaged in evaluating patient expectations. So again, we're faced with our gap, which is not new. It's an old gap. It's been there for a long time related to these patient and provider factors, the system and access issues, the clinical care and quality, and the post-op and rehabilitation issues. By trying to address these, by setting this agenda and beginning to inform this agenda, to develop a culturally dexterous communication between clinicians, surgeons, and patients, to engage unreached communities. We want to resource centers that can improve care for minorities and underrepresented groups and under-resourced groups. We want to focus care on long-term quality of life, and we also want to align our expectations and our goals with those that our patients find important. And that is a way I think that we can bridge this gap and address this need to be able to provide care for all populations and give that full access to and utilization of evidence-based care. So thank you for your time. I appreciate, again, the opportunity to be with you this morning.
Thanks so much, Dr. Bush and Dr. Krieger. We do have a few minutes for some questions from the audience. We have a handful here. I have 2 pages of notes. You all gave me so many things to think about. First, a clarifying question for Dr. Krieger. Dr. Krieger, has the Jewish Community Center been invited to your group of faith communities in the work that you've done in Jefferson County?
No, we have not reached out to them specifically. The zip codes that were targeted were 4 to 10, 11, and 12. Because of the amount of violence in those areas, there's not a synagogue or a Jewish community in those zip codes.
Very good. Thank you. And this is a question for both Dr. Bush and Dr. Krieger. And you each mentioned it in your presentation, but if you would talk very briefly about how adverse childhood events may also be compounding the things you described as the social determinants of health with the populations or the work that you've done. So adverse childhood events, that's a term we hear a lot now, and how those could be related to social determinants of health in your work. Dr. Bush, you
take a shot.
I'm a family
practitioner, and I see adults that do not understand the significance and the prognosis of their exposure to adverse childhood events. So they come into the office with chronic physical illnesses and mental illnesses that have been shown to be directly in response to their adverse childhood experiences. Plus, that term itself is multi-generational. So they may have children that are experiencing those same types of events because they grew up with those events and they don't perceive them as being anything wrong. So they have to be shown as adults, and then we have to protect the children from those too. So the workshop, the symposium that's scheduled for May 16th, is actually having the ACEs delivered to both the adults and their children. So that first we're providing education to the public as to what these events are, and then the second piece is what are the sequelae of having exposure to these events. And there will be mental health providers on site to link first to maybe debrief some acute things that may happen as people reflect on ACEs, but also to link them to long-term care. When you're on Medicaid, getting mental health services can be very challenging. And so we make a very strong effort to make sure that the providers, organizations for mental health services in the area are represented, and that there is someone to help navigate with patients through their insurances to get appropriate care. That's all I think I should say now and give Dr. Bush a chance. Thank you.
I think the questions are great when there's no doubt that adverse child events do compound these social determinants of health, and certainly frameworks that we use and ways that we try to think about big problems like disparities pale in comparison to reality, and it doesn't fully incorporate all the complexity of the interactions and the amplification of effects that can occur. Being an ear, nose, and throat surgeon and taking care of many children with hearing loss, I've seen lots of different situations where there are these adverse child events that just create an overwhelming barrier to overcome. For example, a child in a rural town that may have hearing aids. I have heard of situations where the parents of that child have taken those hearing aids and sold those at a local pawn shop to be able to fund and support an opioid abuse behaviors. And when you think of heartbreaking situations like that, it becomes somewhat discouraging and disheartening. That is there any way that a child like that could be able to overcome barriers like that? So it compounds things in many different ways, and the importance is, I think, at least in my research and the way I think about things clinically, is have conversations with many people. That's not just in healthcare, but those are community community members, stakeholders that are within faith-based organizations, school systems, trying to improve what we do as a community to try to help those that are the most likely to fall between the cracks and the least likely to get the resources. And how do we identify them and provide that leveling of the playing field and access to resources? It is a Herculean effort, and it's certainly worth the effort. It's just not an easy problem to address.
Thanks so much, Dr. Bush and Dr. Krieger, for your replies, because, Dr. Bush, you brought it back to exactly what we're trying to do here at the Foundation for a Healthy Kentucky, is to address the unmet health needs of Kentuckians. Your discussion today made me also think of one great example of how the Foundation does health equity work here in Kentucky, and that's with respect to access to care. The Foundation has been funding to groups in Kentucky, Kentucky Voices for Health, Kentucky Equal Justice Center, who have been working on, among other things, expanded Medicaid policy and community engagement for Medicaid and consumers here in Kentucky. And we also did an evaluation. So there's a report from SHADE Act that the Foundation funded from March 2015 through February 2017 to understand the impacts of the Affordable Care Act in Kentucky. So one final example for us here today. My immense thanks to Dr. Bush and Dr. Krieger for sharing their expertise with us, thinking about resources and policy, and really thinking about how disparities in Kentucky affect all of us here in Kentucky. Thank you for your work. Thank you for everyone who has joined our call here today. I will send out an evaluation this afternoon. I would love to hear your thoughts on today's webinar, hear ideas for future topics that we may include in the Health for Change training series. Again, if you aren't already following the Foundation for a Healthy Kentucky, please join us on social media, on Facebook or Twitter, and also sign up for our e-newsletters via our website. Rochelle Seeger with the Foundation for a Healthy Kentucky, honored to be on the webinar here with you today and to be serving all of us in Kentucky. Thank you for your time. Have a great afternoon.